Hello and welcome to the Nurse Rosa's Insights podcast. I'm your host, Rosa Hart, and today I'm joined by Lynn Carroll. He is the Chief Operating Officer for HSBlox, and he's a strategic leader. So I'm so thankful to get to talk to you today and learn from you because you've been at the forefront of value-based care for years now. So thanks for making time to be on the podcast with us today.
Hi, Rosa. It's great to see you again. Great to be here today.
Yeah. So when it comes to value based care and collaboration, what's one of the most common misconceptions about value based contracts that you think clinicians and health systems are still holding on to?
Well, I think some of the challenges in the value based area are, how will I be successful or how will my organization be successful? Because there's still a good mix of fee for service business out there. And it's been the traditional way of reimbursement. And so as different program designs come to the fore, there's always going to be some apprehension or concern about what does it mean for me and my organization. And some of those things touch on population health characteristics, who might be in the cohort for a population that's at risk. Also might be looking at different ways that information is shared or coordinated amongst different care team members, which can impact success on both the cost containment as well as the outcome side of these types of programs.
So, Lynn, what got you into healthcare specifically?
So I was actually a senior at the University of Illinois, and I had a senior project to do, which I ended up taking on the installation of a budgeting system for a provider sponsored health plan. And that led to ultimately, I ended up being in the finance department, running finance there for about 12 years. And this was back in the early 90s through about the 2000 timeframe. And we were doing a lot of value-based programs. They weren't called that at the time. They were typically global reimbursement programs, procedural bundles, and other types of what today we would typically call alternative payment models. So it was right at the start of what ultimately today is called value-based care.
Yeah. And have you seen that impact like your family or people close to you as far as working in fee for service versus a value based care model?
Yeah, sure have. So, from a personal standpoint, I've actually was end stage renal and had to have a kidney transplant. And so I was actually on dialysis at one point in time before my transplant. But the interesting thing during that experience was that I applied for Medicare because you're eligible as an end stage renal disease patient to apply for Medicare. And that led me to understand a lot about coordination of benefits between Medicare and commercial programs because the whole time I was on dialysis, I actually worked full time. And whenever I needed to travel, I'd arrange for travel, dialysis, etc. And of course, my commercial plan was the primary payer until you get to the coordination period, which is very interesting toward the end of the time frame. And I learned a lot about navigating the healthcare system as an end stage renal patient. Absolutely.
It's incredible. How long ago was that?
This was about 2004 time frame, and I had transplant in 2007 time frame. So it's been
Wow.
an interesting journey, to say the least.
You're almost 20 years after a kidney replacement. That's amazing. I'm so excited for you. That's wonderful.
Yeah, it's been a great journey, and I was fortunate I had a living donor in my brother, and he's
Oh,
doing well. And we just celebrated the anniversary of the transplant a few weeks back.
so does he hold that over your head much? Like, hey, I gave you a kidney.
Now, I mean, he was a great athlete and a distance runner, so he was in great shape at the time that we had the transplant done. And as a result, I got a healthy living donor kidney and from, a great brother.
That is amazing. Well, as we are talking about based care and those kind of models, a lot of times nurses are really focused on providing valuable care and not wanting to think about the money side of things.
Sure.
You're like, that's for a different department. So we can just think about what's good for the patient. But the thing is, it really does affect what we're able to do and whether or not we're even able to provide standard of care. So, as we encounter these issues, how can nurses and care coordinators, like nurses, play a bigger role in achieving these goals, moving towards more value based payment models?
Well, a couple things. I think, first of all, they already play a significant role. As you look at the different designs and different programs, a lot of these programs also incorporate a uh, patient experience, provider experience component, and also a quality component, all of which are touched on by nurses in the workforce, particularly in care coordination and in care teams. And one of the things that we strive to do at HSBlox is make it easier to exchange documentation. We are focused on, for example, primary care and specialty care, and then now also a relationship to the hospital because specialists impact the quality measures that hospitals are held to. And a big portion of healthy outcomes is exchanging information as quickly as possible and accurate information amongst the care team. And where we see a lot of that information ultimately handled and managed is actually by nursing teams.
Yeah, that's so true. I mean, as a nurse, I've definitely been caught in the how do we transmit this information between facilities if you're transferring patients between facilities or getting your records from before they came in the hospital and things
Right.
like and there can be a lot of barriers with that. So, are you saying HS Blocks mostly works with interfacility record exchange, or do you also work with like the patient facing side?
So we do have some patient facing pieces for engagement. So we have a care engagement tool set within our application set that allows for outreach, coordination, some referral management, and some document exchange components. Most of our work is done facility to facility or through exchange networks. So recently, there's been a rise in some of the integration being point to point communication using direct messaging through entities that are now referred to as health information service providers or HISPs, HISPs. Several years ago, they used to be referred to as electronic healthcare network accredited organizations through an organization called EHNAC, and today they're called HISP certifications that allow integration between different endpoints within the ecosystem. So primary care offices, surgery centers, hospitals, etc., can more real-time nature as well as across multiple care team members exchange information.
And then how do you maintain the data security across all of those transitions?
So most of this information is under encryption. And one of the things that is important to us actually is patient data sovereignty. And so ensuring that patients have agreed to exchange information in situations where it may not be part of treatment, payment, and healthcare operations. And there may be some reasons to exchange information. And we like the idea of patients having the ability to weigh in on exchanging that information, as well as know where it's been shared and have ability to understand what their entire record looks like. So access for them as well to be able to get chart related material when they need it. And that's another one of the things that's happening with the HISP movement within the healthcare industry.
Yeah, and so are they able to, through HS Blocks, do like access their own information like on an app on their phone, or how does that work for them?
So we have a couple different scenarios. We have a progressive web app, which takes care of the mobile piece. Then we have a portal component that faces outward. Usually that would be branded by somebody who's using our stack. So it usually would not carry our brand. And so we have provided the tools necessary for folks to be able to engage patients, exchange information, do patient surveys, gather information about feedback with regard to outcomes, change in status, satisfaction, those other components of value based programs that impact reimbursement components of these different designs.
So is it kind of layered, like it would integrate with, say, Epic and MyChart and things like that?
So the integration actually is through those HISP organizations that
Hmm.
are connected to those endpoints. And so we can do messaging through there point to point to either push documents or retrieve documents using FHIR and HL7 standards.
I'm familiar with that. I've had someone else on here that educated me about fire and how it's the law that they have to be able to have access to those records. So, now what does patient data sovereignty really mean? Because I mean, it sounds good, and the whole idea of you owning your own
Yep.
information sounds like an idea that's really great. But does that and bring in like another potential barrier, like in the situation where someone is having maybe needs an emergency surgery and the hospital that gets them in the ER needs to know if they're on a blood thinner to see if they're eligible for certain treatments. Like, I'm a stroke nurse for one thing, right? We want to know, are they on any medications, or do they have any history that would indicate they're not a candidate to get a thrombolytic to save their life, and it's a very short time window. Is there some form of protecting the patient's sovereignty if they're not able to, like, give consent to share their
I
information
think
that
in
it
certain things, things will fall into the treatment category, right? And they'll fall into payment, and they'll fall into administrative operations. And so in those scenarios, right, data can be disclosed. I think what we're really talking about is more like scenarios where there is steerage going on. There are opportunities to reach out to somebody, right, and enroll them in a particular type of a program. Those types of scenarios where patients can have control over whether they're going to opt into something or opt out of it, for example. But when you think about most of the needs for good portions of the data, it has to do with its use and disclosure for treatment, payment, and healthcare operations. So in most of those cases, those would be covered disclosures already.
Oh, okay, good. Well, that's reassuring because I'm always concerned about that. Because just like you want to protect your information, but at the same time, you want to be able to get what you need and quickly. That's
Right.
it. So you have helped to implement everything from digital payments to bundled care administration. But which innovation are you most proud of and why?
Well, I think we've always been advocates of more episodic types of programs. And so in a previous iteration of our company, we had two sister companies, HSBlox and HSBlox. We had built a prospective bundle payment administration platform. And that particular platform was the first of its kind to really scale, a prospective bundling methodology as opposed to the traditional retrospective review components that have been part and parcel to BPCI from CMS and other even commercial bundle payment programs. So we're really proud of that. Proud of my team, proud of the folks that I've worked with in putting that system together. But we've always taken on, myself and fellow colleagues at HSBlox have taken on more complex types of issues to solve because that's where our passion lies. And that's also where we've seen the biggest challenge in getting these types of programs to be adopted on a widespread basis.
Well, that brings us to the $1 billion question. So, Lynn, are you ready for this?
I'm ready.
Okay. So, if you were given a grant for $1 billion to meet the needs that you've seen in healthcare, how would you like to see it used strategically to have the most sustainable impact?
Well, I think we always think about the patient first. And when we think about the patient, there's interactions with different care team members, primary care, specialty care, hospitalizations when those occur or acute incidents. And this whole aspect of, focusing on outcomes and reducing costs requires infrastructure to do that.
Yeah.
And our view is that the best way to improve patient satisfaction, improve patient outcomes, and reduce costs is to be able to implement these different programs at scale. And so we would be focused on making sure that patient data was exchanged amongst those counterparts within these program designs to ensure the best possible outcome, and things like reduced costs through fewer services being duplicated, more tests being run, appropriate site selection for where services should be rendered, moving things to outpatient environment where possible, at home environment where possible, and then integrating, I think, the other components that impact outcomes like social service agencies and behavioral health. So from our standpoint, we're headed down that path. And if we had $1 billion, we would be focused exactly on further expansion of value-based programs.
Could you completely meet that goal with $1 billion, or would it take more?
No.
Well, there you go.
No, we couldn't meet that goal with $1 billion, and CMS hasn't met that goal with trillions of dollars yet. But the focus is right to try to get 95 to 100% of Medicare patients into value-based programs, and following closely on the heels, right, are commercial programs. And we've also seen a lot more interaction from employers. So we're actually in the direct to employer space as well, where some of these programs make good sense to make the dollar go further for employers and their employees.
Yeah, and being strategic with the spending so that it pays off and results in less mistakes and repetitious things that, like you said, were duplicate tests being done because they can't find the records of when it was done before. I mean, that's putting the patient through a lot, maybe a lot of blood loss, or maybe having to go in, get different scans done. And that can be really time consuming and cumbersome and just add
Sure.
delays to their care.
Yeah, and inconvenient as well, right?
Well, inconvenient, yeah, but I mean, if it's adding a delay, that can be really dangerous, right? If you're checking to see if a mass has grown or if a kidney is dying and needs to be transplanted, like, we
Absolutely.
need it to not be delayed. It's a safety issue too. So,
Certainly.
thank you for the work that you're doing with that, Lynn, to improve communication, 'cause it's like communication is, I think, the hardest thing
Agreed.
across all different verticals.
For sure.
So, well, I appreciate you coming on here today. And if someone wants to reach out to you, is LinkedIn the best place to find you?
LinkedIn's good. Also can hit our website. We've got ability to submit form there, contact us. Happy to talk with folks about what we're doing and find out if there's a way we can help out.
Excellent. And I'll have your links in the show notes there. So, for anybody who's listening, if you have not yet subscribed and you've made it to the end of this episode, what are you waiting for? Definitely subscribe to the Nurse Rosa's Insights podcast. Give it a like and a comment wherever you're listening, or if you're watching on YouTube. Let me know if you learned something, or if you know someone else who is making a difference in healthcare and needs their voice amplified, because that's what we're here for, is to amplify good ideas so they can get stuff done. You can follow me on all the social media platforms at Nurse Rosa Speaks, and I'll have my links down in the show notes as well. And I'll see you in the next episode.